All right, welcome everyone. My name is Sarah Morrison and I'm with Foothold Technology. We have quite a bit of information to get through today, but we'd like to answer as many questions as we can. So if you do have a question at any point during the webinar, feel free to send a chat message to Foothold Technology, and we'll take a moment to ask those questions throughout the webinar or at the end. Now I'm going to pass over to my colleague, Jeremiah.
Thanks, Sarah. Do you guys hear me okay?
Yeah, sounds great.
Great, cool. Hi, everyone. Welcome. We're very glad you joined us. We are very excited to bring IDD providers in Massachusetts a presentation and discussion led by one of our Foothold Technologies senior advisors, Laura Nuss. Laura led a workshop on person-centered planning and the CMS rules at the Providers Council conference last October. And we wanted to bring that information to anyone who either didn't get a chance to catch that presentation or to give you the opportunity to share some thoughts, dialogue, propose some questions directly to Laura today. As Sarah mentioned, don't be shy about using the chat feature. Ask any questions you may have as we move along, and Laura will get to them either during the presentation or at the end. Before we dive in, I want to give you a little bit of a brief intro and some background about Laura. Laura teamed up with our shop at Foothold Technology after concluding a very distinguished career in public service. Laura has experience working with groups up and down the East Coast and has served in leadership roles for the District of Columbia, Connecticut, and North Carolina. She served as the director of the District of Columbia Department on Disability Services for quite a few years, where she led the transformative change of the district's developmental disabilities and vocational rehabilitation service systems. For those of you that are NPR listeners like I am, you might have seen a story about Laura's work in DC, and we've also featured some of that on our blog on Foothold Technology. During her tenure, she worked under 3 different administrations in DC, and constantly championing person-centered thinking, employment-first reforms, no wrong door principles, and then worked diligently to design and implement data-driven performance and quality assurance systems. Before joining government, Laura spent 15 years working in the private sector in Pennsylvania with community-based residential and vocational IDD service providers, and she brings a really unique perspective to her work. As a former provider of services, a state leader, a policy wonk, as I like to call her, and also a family member. Laura's expertise includes all things Medicaid, financial management, rate setting, quality assurance, performance management, and she's really a true advocate for systems change and stakeholder engagement. In fact, she recently returned from a trip to Bosnia, I think it was, right, Laura? At the request of the State Department as part of a human rights observation mission. She's a member of APSI, AIDD, a former member of the NASD's board, and actually former president of the board of directors. So as you can see, really excited to have Laura here and share some expertise with us. And so without further ado, please join me in welcoming Laura Nuss.
Well, thank you, Jeremy. Can everybody hear me? Are we good?
We're good.
Okay. I'm happy to be here this afternoon, and for those of you who were here last week, my apologies, or 2 weeks ago. But I'm going to talk this afternoon again about person-centered planning, the CMS rules, and then really how it bleeds into our implementation for the HCBS settings rules, which I know Massachusetts and providers across the country are dealing with, as we are now in the 3rd year of implementation of those new rules. So I'm going to just jump right in on some brief background about those rules and then get into the rest of the presentation. The person-centered planning element of the rules really a lot of people are surprised. The IDD service system has always really embraced person-centered planning, and so we probably always assumed it was part of the requirements for CMS, the Centers for Medicare and Medicaid Services. But in fact, it really was not. In 2008, they encouraged it in their technical guidance. In 2013, they added it for managed care programs, and then in 2014, with the publication of the new settings rules, they finally put it into regulation. And it really forms the basis of what they like to consider a rights-based approach to person-centered planning, meaning really putting choice and control in the hands of the people receiving services and supports. And you see that throughout both the person-centered planning rules and the settings rules. The 2014 rule covers in person-centered planning the actual process that's used, the resulting plan and its implementation, and obviously the review of the plan. In Massachusetts, obviously you have state case management that leads the planning process, but the providers are clearly key members of the team and are obviously implementers of the resulting person-centered plan. What you're probably seeing as new in the process, or maybe not as new because Massachusetts has often been pretty advanced and in the forefront of person-centered planning, but what is clearly in the regulation is that the planning process really has to be driven by the person. We've often given kind of lip service to who the person wants to be included in the planning process, where it is, what time it's held, but in reality we know that often kind of falls by the wayside, and that really has been emphasized in the actual rule. The rule requires that the information presented during the planning process is done in a way that the person can really understand it and helps them make the kind of informed choices and decisions that are expected to be made on the part of the person or the people supporting that person in their decision making. It has to include cultural considerations, be done in plain language and in a manner that's accessible to the person. So when you have a plan that many of us are familiar with, that's long, that's written in pretty dense English, that often is not a plan that people with disabilities are going to be able to understand, or even sometimes the people who are supporting that person are not going to understand. And so the rule is focusing on the plan itself being done in a manner that really a person can understand the actual document. The rule also requires that there be actual strategies outlined to solve conflict or disagreement with the process, including conflict of interest guidelines for all the participants, trying to put up walls and barriers between people who might have other interests in the outcome of the plan that may not necessarily be supporting the best interest of the individual. So trying to just be aware of the fact that different team members might have different interests or ultimate goals that might come out of that plan. And for the settings rule, it has to record the alternative home and community-based settings that were considered by the person. So what that, as that evolves into the settings rule, the most obvious would be if the person is in, let's say, a pretty restrictive residential or vocational day program that doesn't provide the kind of access to the community that perhaps other alternatives do. The plan itself has to go into some detail about what those other alternatives were that were considered by the person, and in essence why they chose the setting that they did. The plan itself, again, has to reflect what's important to and for the person, and I'm sure everybody on the call has heard that language, the to and for. What's important to a person is not always the same as what's important for a person. So making sure that both of those things are addressed. And then this next bullet is really gets the core of the integration emphasis in the new rules, in that the plan itself has to reflect which setting the person has chosen and whether that setting in fact supports the access that the settings rules is driving at, including employment and work in competitive integrated settings, engagement in community life, control over personal resources, and that very vague statement, and receiving services in the community to the same degree of access as people not receiving HCBS services. A lot of us have trouble with fully understanding that last phrase, and it's the part of the rules that we're all striving to really fully come to grips with in delivering specialized IDD services. And again, these last 2 points are kind of reiterating the previous about it has to be understandable to the person who's getting the services and to those who are supporting him, and it has to reflect that the settings people are getting services are chosen by the person. So as I think it's clear, the person-centered planning requirements really are fully integrated with the settings rule itself. They really form the foundation of home and community-based services. And again, it emphasizes how choices have been made, and it emphasizes individual rights, initiative, autonomy, which really is the essence of being person-centered. And then the evaluation of a setting for compliance, to be in compliance with the settings rules, is based on the nature and quality of the person's experiences. And you evaluate that based on how well you know the person's real interests, preferences, and goals relative to a community life. And so person-centered planning is how you get to know what the person's real interests are, what their preferences are, and what their goals are. And through that, you're going to be able to move towards compliance with the settings rule, pretty much regardless of the kind of setting that the person is getting services in. Again, the underlying themes that I'm sure you're hearing about is focusing on individual strengths, needs, and preferences. This issue of personal control, meaning that the person really has to have legitimate influence over their daily routine, over the choices that they're making on a day-to-day, hour-by-hour basis. Focus on what really is informed choice, and that goes into really how does a person know what their choices are and how did they make that choice. It's easy for a person to say yes or no, but if they're not really understanding what those choices mean, then that's not an informed choice. And then, of course, the focus on community integration and employment, which is a focus both by CMS, but then also by the Americans with Disabilities Act and the subsequent efforts that we've seen over the past couple of years by the Department of Justice.
Hey Laura.
Mm-hmm.
Quick question for you. There's a question here about sort of informed choice and sort of tips internally on how to sort of do that check to make sure that you are truly operating in a way that is informed choice. Are there tips or experience that you might have had in a particular area that would be helpful for that?
Sure. There are a number of ways, and I go through a little later in the presentation about guided discussions, which is one way, but throughout, to make sure that a person has informed choice, there's usually a series of questions about whether, in fact, a person has ever tried a different service, whether they visited different service settings or providers, whether they even in fact know that they can make changes in services or providers, whether they've ever talked to people who have done different things, who have worked, who have experienced different kinds of services. So it gets down to trying to focus on an experiential basis. Has the person experienced any kinds of the alternatives or talked to people who know about those alternatives? And then being able to document those exercises, if you will, that you go through to help document that informed choice.
Excellent. Really helpful. Thank you. And apologies if I jumped the gun there.
That's okay.
Thank you.
That's all right. So, you know, some of the simple principles that people are focusing on is really focusing on helping people learn how to take charge of defining the direction of their lives. And again, this kind of goes to what Jeremy just talked about. How do people know what it is that they might want to do with their life? So, you know, people with disabilities aren't going to wake up one day and say, oh, you know what, I think, you know, I'd like to learn how to, you know, work in a bakery or see what it's like to live in a different kind of setting. So it's really going to be focusing on helping people learn what it means to make decisions and taking control in certain areas and helping people figure out what it is they want and how to get there. It's going to require being willing to work on difficult goals. That's something that really has been an experience with different providers and different agencies is rather than saying no or just discounting a person's potential dreams or interests, figuring out how to get on that pathway that might lead toward the outcome that a person's looking for, and recognizing that it's not going to happen overnight, but kind of chunking it up in small steps. Obviously looking outward to the community instead of inward, recreating community, but instead really thinking about how can we implement support programming that can happen in the community itself rather than within the residential or day and vocational program. And then really spending time trying to figure out what the barriers are to a person's interests or the kinds of you know, dreams and outcomes that they have, because obviously the barriers exist or we would have done it already. So really thinking about what those barriers are and trying to you know, attach and go after them. And so informed choice, as I briefly talked about, it really isn't just a form, and we're encountering this with CMS quite a bit in terms of how did the person know the difference. And so, as I said, have they ever talked to other people? Have they ever visited other places? Do they know that they can make changes? Do they know what the differences are? Those are the kinds of questions that we get when CMS and others really kind of challenge whether, in fact, people are making informed choices about where they want to continue to live or what kind of services they want to receive. And, you know, we as state systems and as providers, it's pretty easy to just say, well, they just, you know, they've always lived here, or they've always attended this day program, and so that's what they want to do. And the pushback is, well, do they know anything different? So how is it that they're making a choice? So that's now incumbent upon us as providers to figure out how do we make sure that they've had other experiences to really explore what some of those options are. So I just wanted to touch on what some of the different states are doing to approach person-centered planning a little differently. And one of the things that we're seeing in some states is really an effort to simplify the documents. I mentioned that it's going to be incumbent upon states to be able to create plans that are in fact understandable, both to the person, their support family, their people that are supporting them, and the staff who support them. Certainly using a lot of discovery tools. I'm sure you're seeing that in Massachusetts, that emphasis on discovery, and it can be a vast number of tools that are used. Training people with disabilities themselves to be more empowered in the planning process, as well as family members. And that really goes to the same issue of how can we expect people with disabilities who have been really service recipients all their lives to take a more active role in the planning process and decision making if they really just have never been provided with the kind of support and training and information that everybody else has. And as I said, focusing on what informed choices, focusing on assessment and discovery, not just once a year, not just doing an annual assessment or an update of an assessment, but building it in as part of ongoing experience as a service provider, as they're implementing programming, that the discovery process is really part of planning and service delivery in and of itself on a daily basis. And then another thing that we're seeing is developing what we call guided discussions for team members to get past the yes or no answer. And guided discussions, I just wanted to go into a little detail about that. And just a couple of the examples. We do this because it's difficult when talking with somebody who, again, hasn't necessarily had a lot of experiences, or even just our staff. We all fall into the easy habit of saying, you know, or asking somebody, would you be interested in doing this activity? And the person just says no. And we kind of leave it at that. And so building in some guided discussions that help staff and team members really go through a process to think about, well, how else could we either do this, or how else could we explore and help the person think about whether they might want to do something differently. And so guided discussions could be about the programming that a provider agency is doing, like those that are on the screen now, thinking about the activities that you're doing while you're implementing a goal, stepping back and thinking about could that take place in the community rather than maybe in the home or in the day program. And if it can't, is this the person's choice? And if it is the person's choice, what alternatives has the person explored with your support? And if they haven't, what are the barriers to exploring some of those alternatives, or what would have to change so that the person would spend more time in the community with people who do not have disabilities, which is, again, the ultimate objective of the new CMS rules. So it's just kind of putting in place a standard process by which you really evaluate the activities or the goals that you're doing, and really thinking about why is it that we're doing it the way we are and how could we change it. We've also done guided discussions specifically around employment because, again, a lot of people don't know about employment. The vast majority of people we support have never worked. And so, again, coming up with a series of questions, and I won't go through them, but, rather than just saying, would you be interested in having a job, and the person says no, you kind of move on. So instead, really spending time probing about areas that might have something to do related to employment, like earning money, like learning something new, meeting people, what they like to do or what's important to them, what worries them about employment, and then ultimately, and there's a whole series of questions that you can develop, but then ultimately thinking about doing goals that, if not directly leading to employment, specifically thinking about how do you build the stepping stones that might help a person be on the pathway to employment. And that can be really anything: shadowing people, volunteering, learning about travels, how to get around, personal safety. Anything that can really help expand the person's knowledge about employment, community participation, interests that might help them down the path. And again, it wouldn't necessarily be a job, but it can start leading to alternatives to what they're doing that might get them in the community, and start thinking about alternatives. So, in real just basic terms, in the person-centered planning process, during meetings, we've all experienced planning meetings where everybody sits around a table. We all update last year's assessments. We might read assessments in clinical terms or professional terms. We basically just update last year's goals, and then maybe line up our waiver services and the providers, just like we always have, and not really do much in the way of thinking anything differently. And really what this is looking to do differently is having people who know the person well really use person-centered tools to really do much more in-depth discovery about the person themselves well in advance of the planning meeting. having a planning meeting that is really a discussion with the person and those who care about them. And then really pursuing goals that follow a pathway to avoid really what the person doesn't want and really help the person move closer to what they do want. And really looking at goals that really move away from, you know, a lot of the artificial, I like to call, programming that, you know, simply basic skill development, and thinking about it more in terms of meaningful outcomes that are more functional in terms of what people do to just live in a daily life and in the community. And then attaching services and supports to support the person and their goals that really do look to the community and generic supports, and developing natural supports and using Medicaid and waiver services last.
Hey, Laura.
Yep.
I have one more question here that I think ties in perfectly with changes in PCP here in practice. So the question is, I work with an HCBS waiver for children who are in foster care.
Mm-hmm.
They do not always have a choice. How does that work under PCP?
That's a good question. So don't always have a choice, certainly in foster parents. I think, there is going to be that balance, particularly with children. You know, the important to and the important for question. The important to is what is really important to the person. In this case, the child might be a teenager, but it has to be in balance with the important for, and that then might be the requirements of the foster care system, might be protection for the person, and you know, just quite frankly, the kids don't have the same kind of autonomy about making decisions and choice.
Cool.
So it's unfortunate, but you know, kids don't really have as much choice when it comes to foster care services and systems.
Thank you. Hopefully that answered the question, and if not, please don't be shy. Keep the questions coming, and we'll get them here or at the end of the webinar. Thank you, Laura.
No problem. You know, changes in service delivery. I know people in Massachusetts have seen a lot of this. You are seeing your movement away from large state facilities and congregate residential settings. Massachusetts is, if they haven't already, implementing rules that new residential settings won't be any more than 5 people living together, and that you have a blueprint for success to advance employment, to move away from sheltered work, and then also you've expanded pretty dramatically community-based day services that are not in larger day facilities, and you've worked a lot with ICI out of Boston with a lot of technical assistance in those areas for day services. There's also quite a bit of support in vocational rehabilitation and labor for increasing opportunities, especially for young people to transition to employment rather than what we consider day habilitation first. And that is really a nice pairing with our home and community-based services. So vocational rehabilitation has really ramped up working with youth in high school to expand their opportunities for job experiencing jobs while they're still in high school, and VR has also implemented some limitations about whether young people can move into what is anything that's not competitive employment first. So there's a lot of synergy between both rehab and CMS around advancing community integration. We're seeing services that are delivered in community settings, the same as people without disabilities. That is certainly many states, as in Massachusetts, are designing specific services that can only be delivered in community settings with people without disabilities. And then for the provider community, we're seeing increasing competition between and among providers, because as states really focus on the question about informed choice, it really empowers more people who are receiving services to be able to make changes in both the services that they might select and in the provider that's delivering that service. And so we're seeing provider agencies in some states really advance how they market their services and how they talk about how they are helping people really become part of their communities and responsive to what people want rather than just being a service provider. You should see goals being measured by the achievement of personal outcomes, and I'm pretty sure you're probably seeing that in Massachusetts. The same with quality being evaluated in the same way, instead of simply quality being measured about whether a place is clean and whether goals have been implemented. You're starting to see now quality being measured by whether people are actually achieving the kinds of things that they've identified as being important to them. And then increasingly braiding of funding, meaning supports coming from different systems, not just home and community-based waiver programs, but really wrapping around individuals with different services and different funding sources, paid and unpaid, and moving away from the thought that once a person enters the DD system, if you will, that the formal DD provider network becomes kind of the all-in-one service provider. So we're seeing less of that in some states. A lot of provider organizations have really thought about what does it take to become a person-centered organization. And what that is really just kind of taking person-centered practices and thinking about what does that mean to the organization as a whole. A lot of people talk about it as really transitioning from replicating, being a provider that replicates the community for people, to helping people become part of that community. And when people really do it intensively, it really requires a change in the values of the organization, from leadership to the people that are in the organization and the policies that guide the organization. And really focusing on what the people that you serve, how their life is, and how their what the changes are in their life versus simply the old measures of quality. And organizations that are doing that really have to evaluate everything about their organization. And one of the places that you really start is with personnel. if you really want to be person-centered and person-focused, a lot of that has to do with how do you, what do people think their role is in supporting a person with a developmental or intellectual disability? Is it to really support people to explore and grow and really become part of their community, or is it more of a paternalistic, maternalistic kind of view to just take care of somebody? So really thinking of how do you hire people and who do you hire? And if you think about who does the hiring and who does the training for your organization, you really have to think about, is it the right people who are doing the hiring and the training? In that, is it the people who really embrace the changes that you want to see happen in your organization? Or is it simply your senior staff or senior managers who may not necessarily have made the changes themselves? Likewise, what do you reward in your organization? Do you reward people who really are out there helping people become part of their community? Who are the leaders of your organization? What do you really spend your time that you're working on? Who's advising you and your staff? And how do you evaluate success in the organization? So it's really kind of changing a thought process about what does a successful organization look like, what does it mean, and what do you really value when you turn it around from simply being a service organization to one that really is empowering people to control their lives and really become part of their communities.
Hey, Laura, I have another question here. Are you seeing specific things that agencies are doing to sort of up their game with documentation methods? There's a piece here about sort of integrated billing, service plans, reporting. Anything you want to say on that for just a couple minutes?
Sure. The documentation, there's a lot of different strategies. One is making the documentation certainly connected to the plan, but connected in two ways. One is where you're going to be really easily documenting the discovery process, because without ongoing discovery about what a person is doing, what they might like, what their response was to certain activities, that has to be able to be recorded pretty easily. The other is setting up your documentation system, preferably electronic, with easy to choose choices. If you want to really emphasize choices in a person's daily routine, weekly routine, as you have discovered some of those options, building it into your data collection system so that staff can really have right in the documentation system, here are several choices that the person has already indicated has interest in, and present those options to the person. And then you can easily select which one was chosen, and you don't have to, the staff doesn't have to spend a lot of time trying to figure out, well, what it is that the person likes to do, what am I supposed to do today? So building those choices right into the documentation system. And then likewise, the outcomes and goals should be linked right into your billing system, so that as you implement those various programming outcomes and goals, that should be linked obviously to billing, but it also should be linked into a method by which you can evaluate quality. If you set up your documentation system where you can really track achievement of some step-by-step outcomes for individuals, then you're going to be able to evaluate both at a staff level and then also organizationally for your whole agency, how well is the agency achieving the goal of helping people really achieve actual outcomes that they wanted to achieve. And by doing that, you can literally use that in marketing, for that matter, where you can actually track in an electronic fashion how successful the organization is at helping people achieve their goals. I don't know if that's helpful.
Nice. Thank you.
Okay. As I said, changes in practice is really, like I just said, intentionally building in a range of choices into everyday rhythm of the service day, intentionally building and expanding knowledge of the person's interests and likes, and then really examining where individual rights are being limited, and then translating goals into practical experiences. Really getting away from, again, kind of setting up these fake environments and really thinking about how do you do it in a community like everybody else does. Some real simple things, and again, this really just one. A lot of folks have really moved away from nutrition goals implemented by a nutritionist, and then instead really moving people into the community and using health center wellness groups, health insurance supports, obviously community recreation. And the idea just simply being, think about not replicating what's out there that's available to typical people, instead of just creating kind of a fake environment, which is what we have often done. Again, establishing the person-centered evidence. This goes to documentation. As I said, setting up those easy progress notes to allow a selection from a choice of activities. Using concurrent documentation, which is having it set up with iPads or mobile documentation formats, that as you're carrying out activities in the community, that you really kind of process through with the person you're supporting what their experiences are, and documenting those experiences with the person themselves, in essence, at the same time. And it becomes really part of the activity itself, where the staff and the people you're supporting can really sit down and talk about what it is they're doing, what their experience is, what their reaction is, what they might like to do next, and documenting it as you go. And then in the facility-based settings, focusing on that programming that, again, is going to ultimately lead to self-directing their services or their day, personal growth, personal control, personal preferences. Some quality improvement. Again, I think designing observation and feedback tools that really evaluate performance for people. Again, we don't necessarily just change our behavior overnight. Building measures of inclusion and achievement of goals into staff performance reviews themselves. And then technology to support staff in the community has been something a lot of successful agencies talk about. having really mobile technology so staff can have access to not only the records, but other information that makes it easy for them to work in the community. And then I can't say enough, talking to the people you support themselves to see how they're experiencing the services and their satisfaction. Obviously, there's a lot of challenges with being more responsive to people we support. So obviously, time for staff development, staffing ratios is always a challenge with the rate reimbursement structure. Finding transportation, particularly in rural areas. And then public education and outreach, making, feeling like they're on an island out there, trying to change public attitudes towards people with disabilities. And then lastly, risk management, trying to balance allowing people opportunities to really stretch themselves and learn and experience real life period, and what those risks might be, and helping and learning how to manage and balance those risks. Sure, you've seen these different tools for discovery that are out there to help learn about a person and what their interests are. This is something that's advanced in by University of Missouri through the Supporting Families Initiative. In essence, trying to focus on, don't just look at DD-specific services, but really think about how to support a person using community supports, relationships, technology, and their own strengths. And not just keeping them in a bubble of DD-specific services and supports. And that's it, because we're running out of time. So obviously staying involved and really taking advantage of your technical assistance, of which I know you have a great deal in Massachusetts.
Fantastic. Thank you, Laura. There was one question about, yes, we will be sending copies of this to attendees. So everyone will have that awesome slide with some of those tools on it at your disposal. I have one final question here, and I'll be honest, I'm not sure if you even want to answer this question. I got a little chuckle here. It says, Laura, you have years of experience working in DC. Are there recommendations on things agencies can do to prepare for changes this new administration might bring about? Any words of advice on how agencies can maintain balance and stability until the dust settles and we know more?
That's a great chuckle.
Other than taking your great words of wisdom and keeping the focus on the person, right? And
yeah, I mean, try living in DC. It's far worse. But I think we've all many of us who pay attention to Medicaid, we've all heard about potential changes in Medicaid. The rule, the CMS rule, the settings rule is a rule. It's not going to be gotten rid of anytime soon. But we certainly have heard about changes in how Medicaid is going to be funded, and I think we're all just going to be watching closely. And I think if anything, it really encourages, what I would say is that it should encourage providers to continue to focus on what I had briefly touched on, which is making sure that we're really thinking about wrapping around supports around people and not necessarily being the one size 100% service provider for somebody, but the more we can get people involved in generic services and natural supports, the better we're going to be able to help support people going forward. If there is any kind of contraction in Medicaid funding, then the more we have been creative with using generic and natural supports, the better off the people that we support are going to be.
Wonderful. Sage advice. Thank you. Sarah, anything else on your end that you're seeing that I'm not? Any other questions that I didn't get to?
Nope, that covered everything. Just a big thank you to you and Laura for the work you guys put into this presentation. And a reminder to everyone, like Jeremiah said, we're going to be sending around a recording of the webinar we just saw and the presentation PowerPoint.
All right. Well, thank you, everybody.
Have a great day.